work wonderfully well. Over to Amar.
Thank you very much, Mohan and Sujata. It's a great course which you've been conducting for so many years. Those who are standing, they can come inside also. And so let's see now. Everybody knows about these techniques of implantation. Thought I'll show you something different here. Here you have a patient with microcornea. There's aphakia, that means there's a PC rupture, and there are sombering ring present. So that's a triad. Now why am I showing you this is a case like this. Question comes, what lens do I implant? How do I fix it? And also, how do I remove these sombering rings? Now remember one thing, implantation of a normal IOL in such eyes, in a microcornea, this is a small eye, it's like a fetus in a womb. The whole IOL will get crumpled up. So don't implant a normal IOL inside. We published in 2015 glued IOLs in eyes with microcornea. The reason is very simple. When we are doing a glued IOL, the haptics are outside. So if I take a 7 mm white to white, I only need a 6 mm optic because my haptics are outside. In other words, my message is, in a microcornea eye, please either do a Yamane or do a glued IOL. Even the Canabra will not work, frankly, in such cases. Now, the second problem here is, how do I fix the fluid? This is the trocar AC maintainer. All of you, if you are using an AC maintainer, the problem is you make a knife incision, then you tighten it, then it will be tight or loose. This is a trocar AC maintainer is going 0.5 mm from the limbus, but watch it, it's above the iris. Very simple. Available by Alcon, you can get them from, you can get 25 gauge, any gauge you want. We published this in the year 2016, these trocar AC maintainers, and they are like a valve. So all you need to do is fix them. The problem here is, if you fix an AC maintainer, it can distort the cornea. Can I fix a pars plana? In a microcornea, I don't know where my pars plana is, to be honest. I can create a retinotomy, choroidal hemorrhage, or create some drastic complication. Now once I got fluid in my eye, I'm making my 22 gauge sclerotomy 1 mm behind the limbus. Now if you see sombering ring, which was shown by D.W. Sombring, the problem with them is, if you leave them behind, what happens? The problem is the IOL can tilt. 2, they can drop down. 3, they can produce an inflammation. So there are various complications by leaving a sombering ring behind, a case in which we had to remove it, which had dropped down. So now I've got a multiple factor here. We had published a technique of the scaffold, where we are putting an IOL for PC ruptures for the nucleus removal. Now we thought, can we combine the glued IOL and the scaffold? Now here you see a patient with a sombering ring, microcornea. I told you, clearly we'll use either the Yamane or the glued. I prefer always the glued, to be honest to you. But the second point is, I'm fixing the glued IOL now behind the sombering ring. Now once I have done that, the glued IOL works like a scaffold. In other words, ladies and gentlemen, I've combined the glued IOL we've combined with the IOL scaffold. Now those sombering rings cannot fall down. And with the phaco probe, you can just emulsify these very easily. And we published this also in the year 2015. So now you got the gist of the story. Now look, I'm just going to now go in, implant the IOL. This is another case in which I was doing the same thing, but look, the mistake I'm doing here is, I'm implanting the glued IOL anterior to the sombering ring. Obviously it will not work. I have to go behind the sombering ring. So remember, the IOL scaffold is always behind the sombering ring. So here you see, now I'm just catching the haptic. Once the first haptic is caught, my optic will go behind the sombering ring. Now I do my handshake technique. So you transfer it from one hand to the other. This is the no assistant technique. Catch the tip of the haptic, X-splice. So far, so good. Now I create the chariot's pocket. Now in a microcornea, I'll have extra haptic. So all I need to do is cut the extra haptic with a scissor and tuck the haptics inside. Once my haptics are tucked, my lens is in place, I'll use iris hooks and dilate the pupil. Now break the additions from the sombering ring and the vitreous with the vitrectomy probe. Bring the sombering rings to the center. Now remember, I don't have any fear of the sombering rings falling down because of the glued IOL inside the eye. All I do is remove them all one by one, and you'll see in this case of sombering ring, the sombering rings are removed. So what I tried to show you basically is, we are doing glued IOL in microcornea, plus when you have a PC rupture with sombering ring, use the glued IOL as a scaffold and remove them. Here you can see finally the fibrin glue being applied, and you can see in the microcornea, this was a patient with 8 mm white to white, post-operative day 2. And 1 week post-op, you can see the nystagmus also present, the patient improved to 636. So this is the basic take-home message, where you can use the glued IOL or the Yamane technique. The IOL acts as a scaffold, and also emulsification of the sombering ring happens. The basic problem here is these sombering rings can fall down, and we have eliminated it all by using the scaffold technique. Only thing in this, first we are doing the glued IOL and using that as a scaffold, which makes the whole game bit more easier in such cases, because there's no other way you can manage it. Saying that, I'll just show you another case, and this patient had come to us from Philippines, okay? And when I saw the patient, to be honest to you, I couldn't see anything. Now I'm wondering, what am I going to see in this patient? So here I'm taking off the epithelium, and I'm telling you, I still don't see anything. So I used an endometer, I still don't see anything. So now I fixed a trocar AC maintainer, and you can see faintly an IOL present there. But I'm not seeing very clearly, to be honest to you. So now, what I thought was, I'll make my scleral tunnel incision. Now I made my scleral flaps, I made my sclerotomy 1 mm behind the limbus. Now, watch what I'm doing. I'm passing my endoilluminator inside the eye. Then only I could see the iris claw lens. And one is lying in the vitreous, the other portion is stuck to the iris. So now what I did was, we tried to lift the IOL up anteriorly. So I'm using one hand with a forceps and the other hand trying to dislodge the iris claw from the other portion where it's stuck to the iris. Then finally took the scleral incision, enlarged it a bit, and explanted the iris claw IOL. So here you can see I'm just showing this endometer being passed, catching it and pulling it out. Once that's done, my next step is to do the glued IOL. That's quite simple because I already have a large incision. All I need to do is pass it like a non-foldable IOL. I'm using an endometer from outside we are trying to use so that one haptic can be seen easily. Then I do the handshake technique, transfer the haptic from one hand to the other and catch. There you can see I'm catching it. It's difficult to see with all this cornea being so bad, but either way it is still possible as you are seeing here because of the endoilluminator being used. Once both haptics are out, then my next problem is what? I have to repair this iris, remember that. So here you can see my second haptic caught, pulled out and externalized. Look at the amount of haptic externalized, that's very important. If you go too posterior, you will not have enough haptic externalized. So the moral is, don't go very posterior. I go about 1 mm from the limbus. Once both haptics are out and tucked, my next step is to go for the single pass, 4th row pupiloplasty. So here is simple technique. You pass it from one end, clear cornea, through into the iris. From the other side, through a 26 or a 30 gauge needle, paracentesis. Now railroad the two, bring that loop out. Remember the number 4. Pass it 4 times and pull on either end to repair it. Now once that's done, you can see the mess which the iris happens because it starts cheese wiring in such bad cases. Now another problem here is the desmes and the endothelium is so fibrotic in that area there, I am just not able to continue. So what I thought was, leave the 4th row for some time. Let me try to remove all this fibrotic membrane. Look how fibrotic the area has become. That's the desmoid endothelium, all the fiber optic tissue attached to it. And the worst part is, it's also attached to the iris. So you can see I have to remove it very carefully using the vitrectomy probe, breaking the adhesions from the membrane and the iris. Once that's done and I can start seeing better, then I will try to complete my fourth row pupilloplasty. So you can see now, I'm now completing that fourth row pupilloplasty which I left in the middle. And you can see once that is done, then you start seeing the iris coming back a little bit to shape. But there is a small problem. You can see so much traumatization of the iris there. I'm trying to do more and more of the fourth row pupilloplasty as much as I can. But remember, I have to accept the reality. I'll not be able to do too much. The issue is to see that Purkinje image. That has to be bang centered. So see the image P1 in the center. Now there was an iodine on the top. So those of you who want to repair that, fix a trocar right opposite it. Take a double arm Proli needle. You see the first arm going through the iris into the sclera. Now all you do is pull. And once you do that, that iodialysis can be repaired. Now we do the PDEC technique, which is pre-desmoid endothelial keratoplasty, because we feel this is a great technique as I can use only young donors. And to show the final clipping here in this picture, you'll see the graft attached there. This patient came from Philippines, so remember, he can't come back to me. So I had to finish all in one sitting. So let's see the final picture. This is pre-op, post-op, day 4, and post-op 2 weeks, the patient vision improved to 6/12. So what did we do? We did the iris claw lens explantation, we did the glued IOL, we did the fourth row pupilloplasty with the trocar assisted iodialysis, and ended it with the pre-desmoid endothelial keratoplasty. Thank you very much, ladies and gentlemen.
That was an incredible talk with lovely videos, Amar, as usual. I think what is important is Amar has shown that, and we have also had a huge experience since 2007, the versatility of glued IOL is something which is even in a cornea which is not very clear, as he rightly showed, we can go ahead and externalize the haptic as long as you follow the simple basic protocols.